by the first question related to pancreatic cancer for Muhammad. Muhammad, do you have access, or I can read it to you?
Read the question, Imad Billah.
All right. So the first question was, with the non-availability of nab-paclitaxel in many centers, what would be the preferred regimen after FOLFIRINOX in very fit patients?
So now we are talking about evidence, and we are talking about availability of medication. So I think this is an issue that is in all the hospitals. What I think that you should plan your treatment ahead of time. So what I do is from the day one, if I see a good fit patient with pancreatic cancer, I order the Abraxane upfront for the patient. So in case the patient progressed, I will use it. If I can't use it for the patient, I might use it for other patients. So all the time I have a stock for the Abraxane. Now gemcitabine is all the time is an option. Again, the issue with non-liposomal irinotecan, it's also again the issue of availability. So I believe it's planning for your treatment from ahead of time is the way to go.
All right. If you allow me, Abdulrahim, we have many questions for Muhammad. Can we proceed or move?
No, let's one by one, and we will do it. Muhammad, can I ask you to sit there? Yeah, so moving to the next question, and that will be to Dr. Saif. Dr. Saif, we know most of radiation oncologists, usually they don't like to irradiate upper GI because of the side effect and everything. And the question that we ask ourselves all the time, selection about long course versus SBRT for people with locally advanced disease. Can you give us your ideas and thoughts?
For the, SBRT and long course, usually about, the size of the lesion. So above 5 centimeters, usually it's not suitable for SBRT. It is not absolute like contraindications. It depends on the measurement of the dose and how much we can, save the duodenum, and also if there is any clear invasion to the duodenum, that's contraindication for SBRT. If we have lymph node as well, so most of the people will not include this patient to SBRT. So we'll do chemorad to include more big field, include multiple, elective node irradiations.
Great. Dr. Imad, before going back to Muhammad, I have a question to Samah.
Go ahead.
Dr. Samah, you know that I treat usually prostate cancer. And in prostate cancer, after progression, sometimes we give ADT. That was a question by one of the audience as well. Is that concept applicable to neuroendocrine tumor? Like, for example, if someone progressed on octreotide, do you still give octreotide with your systemic treatment? Any evidence that you're aware of or trials? Samah?
Sure. Yes, it's actually an excellent question. We do have some evidence. We have the COBRA 2 trial, which was actually using basilotide after progression with everolimus. And it did show that there is no durable benefit, for which actually the ESMO guidelines make it very clear that they don't recommend continuing upon progression unless the patient is symptomatic.
Good, thank you. Dr. Imad?
All right, another question to Muhammad. So for those patients with locally advanced pancreatic cancer, do you prefer to do surgery after normalization of CA19-9?
Imad, we can't hear you. Can you please repeat your question?
All right. Question to Muhammad. So in patients with locally advanced pancreatic cancer, would you prefer to do surgery after normalization of CA19-9?
So it depends if we are talking about locally advanced resectable or unresectable pancreatic cancer. So whenever I deal with pancreatic cancer with locally advanced, I think they are metastatic at presentation. So we have to offer systemic therapy for some times to make sure that the patient really does not have metastatic disease. In addition, I don't think we have such, number of cases that you can convert the patient easily to from unresectable to resectable like other tumor. So the short answer, I think it's primary systemic therapy. And if you have a good response, I think it's really a big surgery to have I would go for
radiation, and after.
Thank you, Abdurrahim.
Yeah, so another question to Dr. Saif, that's from the audience, just one second. Yeah, so the question about the SPRT after surgery, like if you have someone, for example, with a surgery for curative intent and they develop metastatic disease and they had complete response minus some, the role of SPRT for those patients, do you prefer to patient?
For, I mean, pancreatic cancer oligometastasis is very rare entity. I mean, we did some cases, but unfortunately they were general for role of SPRT. It depends on the location, the peripheral location we can treat. We do like fair amount of cases in the colorectal cancer, not pancreatic cancer, but oligometastasis and pancreatic cancer is very, very selected patients.
Dr. Ahmad, do you want me to go with the next question or no?
Go ahead.
Yeah, Dr. Samah, for the neuroendocrine tumor, the intermediate tumors or neuroendocrine carcinoma, usually they do not respond well to chemotherapy in general. That's based on observation. You can correct me if I'm wrong. Can you tell us your favorite regimen for the intermediate? For example, if I tell you like the liver neuroendocrine carcinoma, usually they behave more aggressive than moving from one line to another.
Sure. So again, it's based on a case by case. If, for example, I have a patient who's really aggressive, then I would prefer to start with, I know that the response of chemotherapy is not high, but for example, if the patient is symptomatic, I will rather start with chemotherapy more than PRRT. We don't have access. Again, sequencing, what's the best is, we don't know yet what's the best sequencing, but I would say discussing every case in tumor board is really important.
Great. I think there is a room for one more question. Dr. Ahmad, can you go
All right.
with the...
Mohammed, this question is very important because I would say majority of people are from Ministry of Health. And this is actually posted.
You're muted.
Am I? Hello?
Ahmad.
Really?
I can hear you, Ahmad.
So Samah, can you hear Samah?
No, go ahead. نسمعك. One more time, Ahmad.
So the last question, yeah, Muhammad, is majority of your audience are from Ministry of Health, and this is actually posted in the Q&As. So they're asking about the accessibility. So part of the management of pancreatic cancer is NGS. They don't have access. So they're looking for your advice and solutions.
Well, I think this is really an issue with the precision medicine in general. However, I think there are still many ways that you can help your patient with pancreatic cancer. So first of all, I think palliative referral from a patient with metastatic cancer can help. I know we are focusing a lot about medications, but early referral to palliative care reported to improve the quality of life and survival of patients with pancreatic cancer. If you have a young patient and you cannot do BRCA testing, for example, simple thing you can do is just expose the patient to platinum-based chemotherapy, because in case this patient carry a germline mutation and you cannot test for, or even a somatic mutation, you expose them one of the most active agent. Then I think it's only small percentage of patients with pancreatic cancer who would be fit for second or third line of therapy. So maybe in those patients, you might consider referring those patients to a place where the testing can be done, especially if they are fit. So this is what I can advise. But I share with them that it's really a headache, and it's difficult to the oncologist that there is a medication or there is a test that can be offered to the patient, but he cannot order it due to accessibility.
Thank you, Abdurrahim.
Thank you for this interactive session. I will ask Mohammed Saif and Dr. Samah to answer the rest of the question online. And by this, we will end this session. And back to you, Dr. Kannan.
Thank you, Abdulrahim. And I also thank the speakers, Dr. Samah, Dr. Saif, Dr. Garni. Thank you, Imad, for, as usual, leading a great discussion. So we'd like to end this session now. So for the virtual attendees, we will have a break until 10:30. We're going to be back for the session on cholangiocarcinoma and gallbladder cancer at 10:30. So thank you all.
Great job, Kannan, and the rest of the team. Thank you all.
Thank you, Imad. Have a great day.